Let's talk about daptomycin. For anyone in infectious diseases, that name brings to mind a critical last-line agent against some of our toughest bugs, like MRSA and VRE. But here's the thing, its power comes from a real paradox. The very mechanism that makes it so unique is also the source of its very specific limitations and toxicities. So, to use it right, we really have to understand it inside and out. Let's dive deep.
Here's our game plan. We're going to start with how it works, right down at the molecular level, and then see how that science plays out in clinical dosing. After that, we'll get into the risks and warnings you need to have on your radar, take a look at the ongoing challenge of bacterial resistance, and then we'll wrap it all up with a quick knowledge check to put everything together.
All right, first things first. To really get a handle on daptomycin, you have to understand its mechanism of action. This process is, well, it's elegant, it's complex, and it dictates pretty much everything about how we use this drug, both for success and for safety.
So what exactly is daptomycin? Structurally, it's a cyclic lipopeptide. It has this ring of amino acids and a lipid tail. But honestly, the most critical detail here, the one thing you can't forget, is its absolute dependence on calcium. Without the calcium ions that are just floating around in our bodies, daptomycin is completely inert. It does nothing. And that fact is the key to its entire mechanism.
So how exactly does calcium flip the on switch? It's a fascinating sequence. First, calcium binding forces a shape change in the drug, which allows it to clump together into these things called micelles. These micelles then travel to the bacterial surface. Second, calcium acts like a bridge, letting daptomycin latch onto its main target, a phospholipid called PG in the bacterial membrane. Think of it like a handshake. That handshake lets daptomycin's lipid tail plunge right into the membrane. From there, the drug molecules start teaming up inside the membrane, forming a channel. And this leads to a massive, sudden flood of potassium ions out of the cell. The membrane potential collapses, all vital cell processes grind to a halt, and the bacterium dies. And what's really amazing is it does all this without actually blowing the cell apart.
Okay, so that's the how. Now let's talk about the how much. That brings us to pharmacodynamics. The key metric for daptomycin is the AUC to MIC ratio. And for S. aureus, the magic number we're shooting for is 66 or higher. It's all about achieving a really high peak concentration relative to the bug's susceptibility. This is what drives its killing power, and it's the fundamental reason we give this drug as a single, high, once-a-day dose.
So with that science under our belts, let's see how this all translates to the bedside. We'll get into its approved uses and the specific dosing you need to know for different clinical situations.
Let's work through a classic clinical scenario. Imagine you have a 68-year-old male with end-stage renal disease who is on hemodialysis. He comes in with a catheter-related bloodstream infection, and sure enough, his blood cultures pop positive for MRSA.
So here's the million-dollar question. How do we correctly dose daptomycin for this specific patient? You've got to weigh two big factors: the indication, which is serious MRSA bacteremia, and his profound renal impairment. What's the right move here?
The right answer is 6 milligrams per kilogram to target the bacteremia, but, and this is key, the dosing interval gets stretched out to every 48 hours. So why do we do that? In patients with no kidney function, daptomycin's half-life gets massively prolonged, going from about 8 hours all the way up to nearly 28 hours. If you dosed him daily, the drug would accumulate fast, putting him at a really high risk for myopathy. So we extend the interval, we give the dose after his dialysis session to avoid clearing it, and we ramp up our vigilance by checking his CPK levels twice a week.
This table really lays it all out for us. For adults, notice the step up in dose, from 4 milligrams per kg for skin and soft tissue infections up to 6 for bacteremia. And for both, once creatinine clearance drops below 30, you switch to every 48 hours. Now, if you look at the pediatric population, the doses are actually higher on a milligram per kg basis. That's to account for their faster drug clearance. But you'll notice that for kids with renal impairment, the guidelines just haven't been established.
Of course, a drug this potent isn't without its risks, and managing that risk means you have to have a deep understanding of its key toxicities and interactions. These are things that demand our active attention.
The best-known toxicity, the one everyone thinks of, is skeletal myopathy. This shows up as muscle pain and a rise in creatine phosphokinase, or CPK. The protocol is pretty straightforward. Get a baseline CPK before you start, and then monitor it at least once a week for everybody. And the rules for stopping are strict. You pull the plug if the CPK goes over 1,000 and the patient has symptoms, or if it goes over 2,000 even if they feel totally fine. Now, there's another one, much rarer, but it can be fatal, and you have to have it on your radar. It's called eosinophilic pneumonia.
This isn't an infection, it's a strange inflammatory reaction in the lungs. The single biggest diagnostic clue is the timeline. It almost always develops 2 to 4 weeks after starting therapy, and it shows up as a fever, cough, and progressive shortness of breath.
Daptomycin doesn't have a ton of drug interactions, but there is one that is absolutely paramount, and that's with statins. Giving these two drugs together significantly increases the risk of myopathy. It's a pharmacodynamic interaction. Their toxic effects on muscle are additive. So the primary recommendation is simple: temporarily hold the statin for the entire time the patient is on daptomycin. If for some reason you just can't do that, you have to increase your CPK monitoring to at least twice a week.
Next up, let's cover the non-negotiables, the situations where daptomycin is a no-go, and how we have to adjust our strategy for vulnerable groups like pregnant women and children.
Okay, this next point is maybe the most important thing to remember about what daptomycin can't do. Let me be absolutely crystal clear. You do not use daptomycin for pneumonia. Ever. This isn't a suggestion, it's a hard rule based in pharmacology. The drug gets down into the lungs, binds to pulmonary surfactant in the alveoli, and is completely neutralized. It is rendered totally ineffective right at the site of infection. It simply does not work there. So what about special populations? In pregnancy, we just don't have much human data, so it becomes a risk-benefit calculation. You use it only if the potential benefit to the mother outweighs the unknown risk to the fetus. During lactation, we know it's excreted in breast milk, but at very low levels. And because it's not absorbed well orally, the risk to the infant is thought to be low. But, and this is a big one, in infants younger than 1 year old, you avoid daptomycin entirely. Animal studies in newborns showed risks to their muscular, neuromuscular, and nervous systems, so it's a no-go.
All right, let's zoom out a bit and think about the long game. How do bacteria fight back against this drug, and where does daptomycin fit into a modern antimicrobial stewardship program?
Resistance to daptomycin is, well, it's pretty clever. It's not usually one single thing, but a whole adaptive process. The common theme is that the bacterium remodels its cell envelope. You see mutations in key gene systems like MPRF or the DLT operon. And what these mutations do is they increase the positive surface charge of the bacterial membrane. This essentially creates an electrostatic shield that actively repels the positively charged calcium daptomycin complex. The drug can't even get to its target.
And this brings us to a really sophisticated point about stewardship. Let's say you have a patient on broad coverage like vancomycin and Zosyn, and then you find out they have MRSA bacteremia. You de-escalate by stopping the Zosyn. But the switch from vancomycin to daptomycin, that's not just narrowing the spectrum. Oftentimes, it's about escalating potency. We're choosing to leverage daptomycin's rapid, concentration-dependent killing to go after a confirmed, life-threatening bug more aggressively. It's a strategy that's about both precision and power.
Okay, we have covered a lot of ground. Before we finish up, let's do a quick knowledge check to test how these core concepts can be applied in practice.
Here's the situation. You're following a patient who's been on daptomycin for 15 days. They suddenly develop a new fever, a dry cough, and feel increasingly short of breath. You get a chest x-ray and it shows new infiltrates on both sides. What is the most likely diagnosis, and what is your immediate next step?
The answer is to discontinue daptomycin right away. This kind of subacute onset of respiratory problems happening after 2 weeks of therapy is the textbook presentation for eosinophilic pneumonia. Recognizing that clinical pattern is absolutely critical, and the only right move is to stop the drug immediately.
You know, when you step back and look at it, daptomycin really does represent a profound paradox in our field. Its unique power to dismantle the bacterial membrane comes from the very same properties that make it useless in the lung and a constant threat to muscle. And because of that, it demands from every one of us not just a prescription, but a protocol of vigilant respect.